The doctor is the one that makes that decision.
And that can't be made when the doctor sees the woman on her first visit when she has a sonogram. He can't make, or she, if the doctor is a woman, she can't make that determination when the woman is there for the sonogram. Isn't that supposed to be the point, to determine gestational age, to determine the very issue that you're talking about, whether this woman could be and should be a candidate? Because RU-486 is only used from 5 to 9 weeks of pregnancy, correct?
It is up to, according to the FDA guidelines, up to the seven-week period, yes.
And that's occurring at the sonogram visit. So how is the second and the third visit creating? No, I'm just using your reasoning. How does the second and the third visit in any way contribute to the physician's analysis of whether this woman is a good candidate?
Because she is going to be right there in the presence of the physician, and whether anything has changed in that time period of when she's left and come back. Because
Senator
you just
Hager,
said she's not going to be there during the whole time, and whether anything has changed, that doctor can do an evaluation and be able to assess, Senator.
Senator Hager, I'm not a doctor, and neither are you. And this is where doctors beginning to legislate, I think the practice of medicine becomes such a concern. Because I'm sorry, but based on the conversations that I've had with clinicians who practice in this arena, it makes absolutely no sense. In fact, it's absurd to say that somehow taking that dosage in the presence of the doctor in the first and the second visit is somehow allowing the doctor to be more available to her if she suffers complications because she leaves after she takes it. It doesn't make any logical sense, but I'll move on from that. I have another question about that. So we've agreed, though, that under the RU-486 requirements in the bill today,
I'm sorry. Yes.
Under the RU-486 requirements in the bill today, and the woman has to come for 4 different visits.
Up to. Yes.
She's supposed to come for 4 visits.
Right.
We know she's going to come for at least 3.
Correct.
Does it concern you at all, women who utilize that procedure, of course, under the medical standards, are 5 to 9 weeks of pregnancy, that the burden that's going to be placed on a woman to use that as her preferred method is actually going to create a situation where fewer women can access that treatment earlier in their pregnancies, and in fact, that this might have the opposite consequence I think that any of us would want to see, the unintended consequence that women will now appear for later term abortions to access services than they might have if they had the advantage of being able to utilize this regime as their method of choice.
My concern is having the protocols followed, which I firmly believe, and from talking to a significant number of witnesses, testimony, will provide a safer situation. And so if you talk about whether this is going to cause abortions to be at a later term or a date, that is not something that I'm trying to move dates up or back in this bill, Senator.
Can you point to a single incident, a single documented incident, where a woman who did not take the RU-486 regime in the presence of a physician had a greater health risk than one who did?
I don't have a specific date and case right here in my bill packet, but I do know, based on the studies and the statistics, the FDA protocol and others talking about the medical abortion has a higher incident rate of complications and a much higher rate of severe complications.
That doesn't answer my question, but I want to move
I understand,
on.
but I don't have that specific case study that I can read on date X day.
We're creating legislation where we're supposed to be able to demonstrate a significant state interest that does not create an undue burden on women. And based on our conversation, I'm not hearing anything that's demonstrated a documented state interest in requiring that this regime be administered in this manner. That's my opinion, and I know you have a different opinion.
Thank you, Senator.
Now I want to move to follow up on a few questions that Senator West was asking you about on admitting privileges. There's a report that I've read. I'm sure you've read it. I know it's been provided as part of the testimony that's been given in the House and the Senate committees that have heard this bill. And it's a report that was published by the Guttmacher Institute in the spring of 2013. And that report stated that less than 0.3% of abortion patients experience a complication, and only 0.07% of those required treatment at a hospital. And what I'm wondering is, of those ones that did require treatment at a hospital, were there any instances, any documented instances, where women's health was endangered because there was a lack of admitting privileges of the doctor that performed her abortion?
Can you remind me of the date? What was the date of that
Spring
study?
of 2012.
Of 2012, okay.
I'm sorry, 2013, actually.
Okay, thank
Spring
you.
of 2013.
Okay. And you want to know, were there any specific references in that study that provided?
No, I'm asking you, are you aware of the 0.07%, and this is a percentage that's based on a look at this issue across the United States. It's not just limited to Texas. Texas has a very similar record. Of the 0.07% that required treatment in a hospital, are you aware of any documented instance where a woman was somehow endangered by the fact that the hospital she presented to was not a hospital where her performing doctor had admitting privileges?
We had several witnesses just the other day that testified, and here too, that the complications that they had, they could not be tended to there at the clinic, and or when they went to the hospital, the severe complications that they had, they didn't have that relationship with the doctor who performed the abortion.
That's not what I'm asking you.
And I mean, far as this study, I'm a little concerned about this study, and I appreciate you reference it. I mean, this one I think is a little skewed, being a Planned Parenthood study. No offense to be made, but I'm concerned about some of the data in that study.
Do you have specific concerns that you can point to in terms of the data that was gathered?
Well, when we're sitting through this debate and trying to go through the data real quick off the top of my head, I'm going to sit here and point to one specific paragraph or another, but I do believe the data overall, I just call it into question, Senator.
Senator Hager, Senator West asked you the question about whether other doctors who perform outpatient services were required to have admitting privileges within specified distances of a hospital, and you stated that you're not aware of any other instances in Texas where that's required, correct?
Correct.
And I think we would agree, whether you agree with the exact data in the Guttmacher Institute report that we're talking about, that child delivery actually has a much higher incidence of problems for mothers than abortion does.
I remember you asking me this same question, yes ma'am, a few weeks ago.
And I'm curious as to, given that higher incidence of problems can arise in a childbirth, why, if what we really were concerned about here was the health and safety of women in the state of Texas who are expecting, that we wouldn't have that requirement imposed upon their doctors? Or, in fact, in Texas, we don't really even require that they be delivered by a doctor, do we?
No, you and I had that discussion before, whether it can be at midwives and that at home.
So I'm curious as to why in this particular instance that admitting privilege is important, but in other instances where incidence rates of problems are even higher, we aren't having that same concern and we aren't requiring that same admitting privilege.
And I think if you were concerned that we need to work in that area, then I would welcome to work with you and look into it, because you raised it just 2 weeks ago to me.
Well, I actually, Senator Hager, don't believe we should be legislating that, because I believe we're intruding upon the practice of medicine when we do that. And in fact, the Texas Hospital Association has very strongly come out against this proposal, correct?
The Hospital Association?
Yes.
Yes, I've seen a letter that they opposed this bill.
And have you heard the concern, and how would you respond to this concern? Because we, by Texas law, cannot require these hospitals to provide admitting privileges, correct?
No, but a hospital is not, correct, we cannot, they cannot do is discriminate against one doctor based on a set of privileges that another doctor is equally qualified for.
But we cannot require that they admit any particular practice group or any particular physician.
We don't currently require that.
That's right.
Yeah.
So
We can, but we are not today.
does it concern you at all, then, that hospitals essentially would have the veto power of whether abortions could even be performed in Texas anymore? What if there is a very limited number of hospitals that allow admitting privileges for these particular doctors?
Well, today, based on different numbers, whether 50 or 2/3, 50% or 2/3, 60+% of all the doctors do have admitting privileges today at different hospitals that perform abortions. And the question really becomes about those that do not, whether they are skipping around to different clinics and not having the same quality and standard of care.
Well, no, the question actually becomes whether the clinic is within 30 miles of the hospital where the doctor has admitting privileges.
The one provision, yes, the 30 miles, which all abortion clinics today are within that 30-mile range, at least here in the state of Texas.
And are you aware that in the law today, and I'm going to refer to the material that Senator Zaffirini was discussing with you a moment ago, the chart that was provided in the Health and Human Services Committee hearing that talked about the qualifications to be a licensed abortion facility in
ma'am.
Texas
Yes, I
versus an
recall that.
ambulatory surgical center. The licensed abortion facility requires that there be a local backup agreement with physicians in town who have admitting privileges, correct?
That they have to have a transfer agreement.
Yes.
Yes, a transfer agreement, yes.
Yes, and in answer to Senator West's question a moment ago, Senator Dool said that in other arenas, physicians are required to have either their own privileges at a hospital or transfer agreements. But I don't think anyone has been able to state a single instance where a requirement of admitting privileges alone exists. They typically can have either or.
Are you talking about in the current ASCs?
I'm talking about physicians in Texas.
Physicians in general. Okay, I just didn't know what the context of your question was. I
Sorry.
wanted to make sure I heard the exact question.
So my question is, right now in Texas, there are some practices where admitting privileges in hospitals or transfer agreements are required for that particular physician's practice. That was Senator Dool's answer to a question that Senator West asked him a moment ago, correct?
I think that's what he said.
Okay, and so what I'm trying to understand is if in the law today, licensed abortion facilities currently require that a transfer agreement be in place
Correct.
with a local physician,
Yes.
how is a woman's health somehow at greater risk in this arena, which is provided for other physicians in their practice areas? Why is a woman somehow at greater risk where a transfer agreement exists, but a admitting privilege within 30 miles of her clinic does not exist?
The admitting privileges, I believe, ensures another level that that doctor is a peer review and is qualified to be admitting patients to a hospital. It's another level of peer review and qualifications.
And again, I ask the question, can you point to a single documented incidence where a woman's health was risked as a consequence of her doctor not having an admitting privilege within 30 miles of a hospital,
I believe,
of the clinic?
I'm not going to sit here and cite to you that specific incident, and I appreciate you asking me, but I do believe that having this standard is important for improving the quality of care. And I know we disagree on that, but I believe that, Senator.